welcome to another episode of Fertility Talk with Olarunke Thaddeus. On today's episode, we are going to discuss some real practical issue, and the topic is why some IVF treatments fail. I know you are interested in this topic because I know a lot of women have done IVF, and I know a lot would still do IVF. So just sit back and listen. Over time, we have had to see clients with failed IVF treatments. 90% of clients have had at least 2 failed IVF cycles. I remember a particular client with the history of 20 failed IVF. In fact, I also remember of one recently with history of 10 failed IVF treatments. Yeah, and she got pregnant using our specialist, okay? And you know, IVF failing or IVF failure is not a Nigerian thing. It can happen whether you are in Nigeria or whether you are in UK, whether you are in Canada or wherever, India, name it, okay? Just name it. IVF can fail. That is the truth. To have a failed IVF treatment, I know how demoralizing this is, okay? But more demoralizing is this fact that most of the time, the reason why it failed is not given to you, because it's either you fail to ask your doctor or your doctor just say, oh, I don't even know why it fails, okay? At best, you will hear reasons such as IVF is 50-50 or 4 in 13. You know, IVF is not guaranteed. Yes, you will hear all sorts, okay? And the truth is that truly, IVF can fail for no reasons, but not most of the time. To a very large extent, the success of IVF depends on some factors. And if you and your doctor can just help in ensuring that the chances of this factor are maximally utilized, then it will also help you improving your chances of getting it right in your IVF treatment. The obvious issues in most cases when IVF fails is inadequate evaluation and poor interpretation to test. That is one of the obvious reasons. This is why in many of my videos, I will shout, do proper evaluation, ensure you're properly evaluated. You know, also most of the clients are victims of their own request. What I mean by this is that you have done evaluation, your doctor has identified that or you probably need a donor egg or a donor sperm, and you know, you are still insisting that, doctor, no, I can't use a donor egg, I can't use a donor sperm, no, I have to carry it myself. Even when your doctor has said you use a surrogate mother, you just want to do things yourself. So in no particular order, factors that are important in achieving conception include healthy individual devoid of chronic medical illness, good quality sperm, adequate ovarian reserve, normal size uterus with good endometrium, devoid of fibroids, polyps, and uterine adhesion, fallopian tubes devoid of hydrosalpinge, a good and well-experienced embryologist, then a good IVF laboratory, and a skilled IVF personnel, okay? All these are factors that would help you to ensure that you have a successful IVF. And when you get it wrong in all the factors I have mentioned above, then you know what the results will be, okay? So let's talk about ovarian reserve, for instance. Of great concern are cases of clients with negligible ovarian reserve. Even from their anti-malarial hormone test, you will know, okay? And most of these clients will insist to be stimulated, and those whose physicians still embark on stimulating them despite a negligible ovarian report knows how the stories goes eventually. In simple terms, you don't give what you don't have. When a client or a patient is being stimulated, what you are doing in simple terms is retrieving available eggs, okay, that you have. You do not retrieve what you do not have. A patient fails to understand that their egg reserve depletes as they age. No wonder females are said to have biological clock. As a female gets older, their egg reserve depletes in quantity and in quality, and their risk of having babies with chromosomal abnormality also increases, okay? So some clinic will carry out hormone profile, FSH/LH to determine whether you are fit for stimulation or not, okay? The drawback to FSH, LH is that it does not correlate significantly with ovarian reserve, okay? A patient have been stimulated based on good FSH/LH and good intra-follicle counts, but yielded poor or no response. So this is why I would usually suggest that AMH will be done. I still prefer AMH test to FSH. Even in utilizing AMH, of course, it is important that your past IVF treatment is reviewed, okay? And even at that, it is also important to say that AMH is not absolute. You can have a poor response and unfavorable outcome following stimulation, even with GONA-F, in the presence of significantly reduced ovarian reserve. Some clients could be adequately cancelled though, so it is very, very important to know all this before you start your IVF stimulation. Ask your doctor what your ovarian reserve is, and if he feels you would respond well based on what your reserve is saying, so that at that point you'll be able to take a decision whether to use your egg or whether to use a donor egg. Another reason why I would always prefer AMH test is that it gives a guide to your specialist to know the right dose of FSH required for your stimulation, and invariably helps to prevent drug-induced complications such as ovarian hyperstimulation syndrome, okay? Also, it helps to determine the best protocol for your stimulation, whether it is a short protocol, a long protocol. It is also important to understand that the quality of eggs play a very major role in determining the quality of your embryo. So a good quality embryo transfer into a good womb is a recipe to a successful IVF treatment. So help your doctor to help you. If the eggs are good, if the sperm is good, if the womb is good, then you yourself know you have done your best, and you have also helped your doctor to help you to maximize your chances of getting it right in your IVF treatments. Thank you for watching today's episode of Fertility Talk with Olarunke Thaddeus. For more inquiry, kindly comment below. And if you want to book a consultation with us, kindly send us a DM or you call the number showing on your screen, okay? Take care and God bless.